Well, hello and welcome to another episode of Boombostic Health. We are in the wild here at the Healthcare Innovation Summit brought to you by HC1. And we are moving into our next topic here at the summit. I'm really excited to share. First, I'll introduce our guest. We've got Matt Wilson, who I was joined at dinner at the summit here last night, and he has to definitely share some of his crazy things he did out in the jungle, and you'll hear his accent. He's not from around here. Matt and Elliot Josephson, a thought leader in the diagnostics industry, who is here to help us really unpack this topic of really the connection between diagnostics and unlocking more precise healthcare, and ultimately even getting into the world of studies and connecting patients to precision medicines in a manner that is really powerful and different from what's happened in the past. So thank you guys for being here. So maybe just to give a little bit more color on who you are, maybe start out, Elliot, if you could just introduce yourself and share what lens it is that you're coming into the conversation with here. And then if you could do the same, Matt, we'll get into the topic.
Yeah, thank you. First of all, this meeting has been incredible. Just to be this intimate setting and get to know each other more than how we meet each other in conferences is extremely valuable. So thank you for putting this all together. I think that we are now in a world where the patients are driving their care, and that means a lot of things are going to change and already changing. And because of that, I think that some of the systems that we are involved in, we just had a conversation, very interesting to see a payer and a lab sitting next to each other. Things need to change as the industry is changing, as AI is kicking in and making sense of all the massive amounts of data that we have that Steve mentioned. So I am fortunate to have created a platform where I work with many different companies, and therefore I see maybe from a higher view challenges and things that can be fixed. And my lens started in the industry through genetics. So a lot of what I do is related to genetics. Previous careers probably helped me see things differently. So I had some years that I did executive producing of films in Hollywood, which was crazy. A lot of stories for dinners. And before that, I was on Wall Street. So different perspectives that I bring into healthcare, and with a really strong focus on diagnostics. And we'll share more during the discussion.
Thanks, Matt.
Yeah, thanks so much, and agree. It's been a fantastic couple of days. My background is as a physician, and I was involved in research throughout my career as a physician back in the UK. And I've now founded a company called UMed, which is all about being able to bring research to patients that traditionally don't have access to research, and using that access in innovative ways to be able to drive more research, more answers to questions that we need to help drive that whole precision medicine paradigm. Talk a bit more about it, but just to mention that I got lost in the jungle when between leaving school and going to college. I spent a year in Guyana teaching in a border, and it turns out that what I really want to do with my kids is make sure that I get them into Bear Grylls early, because I made all the mistakes and then ended up for 4 days in a very remote area of the jungle. And I hope that I was going to get found.
Right, you did. And we also compared notes on the fact that I too have been lost in the wilderness. In particular on a ill-advised backcountry snowboard run at one point, and that we both agreed we probably, if we ever go to have any kind of expedition together, should have a guide.
Yeah, I think so. I don't think our wives would allow us otherwise.
Awesome. Well, hey, it's great to hear the stories and also to just get to know people in more of a personal way, and thanks for sharing that. So one thing I'll ask on that note, because as you were talking, I thought about this. So my mom had stage 4 colon cancer, and this was back in 2000. Just curious what you just described about bringing this better research that's more accessible for somebody like her who was a patient that was navigating her health journey that was very dire, and her caregivers were doing their best. There wasn't really a connection between her and the research world. It was very ad hoc, I would say, once the conventional treatments had been exploited and they were trying to figure out, what do we do now? Can you talk to how does a story like that change based on what you are doing?
Yeah, it's a thank you for sharing. And one of the things that really struck me when I was involved in research and doing it traditionally was that we always think about studies historically over the last 50, 60 years since it's been formalized as these sort of discrete episodes in a patient's life where you get colon cancer, something happens to you, and then you become part of the study for a period of time, and then you leave that study and you never hear anything more about it. So a key piece of what UMed's doing is turning populations into living cohorts, living research programs, because we see about a significant fraction of most patient populations out there are actually very happy to be part of an ongoing research project where we can not only link their clinical record data, but we can then follow those patients up over time with surveys, with devices, with genetic testing, and then make those patients available for specific studies. But from that, we also get this much broader data set. So rather than it just being an episode where we have specific cancer, what we're able to do is actually follow these patients well before that cancer ever happened. And you can start generating so much more insight and value because you can start seeing what's predicting, what's driving the person to get to that state of sickness. And if you can do that within a meaningful fraction of the population, which is what our platform enables, suddenly you get to be able to do all of these really exciting things. And on the diagnostic side, one of the things I'm super excited about with HC1 is the opportunity to use that as a mechanism to start developing predictive algorithms in a way that the lab doesn't just become this moment in time where you get a HbA1c back and the doctor does something with it or doesn't, but actually that becomes a vehicle for us to be able to gather and understand what are the things that are going to be predicting health outcomes and enshrine that with inside a framework.
That's interesting. Elliot, you've been involved with genomics, which you just touched on as one of the vectors of diagnostics. There's so much promise in genomics, and yet there's still such a huge chasm between that promise and the effect of that information. And there are a lot of reasons for that. I think probably certainly one of them is the caregivers aren't necessarily, they're not cyborgs. They aren't instantly streamed the new breakthrough research and things. So it's like, how do you change the information they have and the training they have? But aside from that, there's some pretty big economic issues as well. So to do what you're describing, where you're advancing the way that we're predicting and engaging in these studies, we need the information. But to get the information, we need to actually be doing the testing, but then it's not being done all the time. And it just seems like kind of a big mess.
Yeah. So my observation is, so I'm involved in a lab that produces a lot of genetic data at scale. And one of the things that they decided to do is they said, we're going to be a cash-only lab. Now, what do you see? You can do pharmacogenomics testing that we're talking about at scale for less than $100. But if you go get a reimbursement on it, it's $800. So the payers are like, no necessity, no need, all the reasons why not to pay for it, and makes it a lot harder to do a test that only costs $100. So I think the challenge, and maybe kind of like following the discussion that Steve and Gary had, is there an opportunity to go to payers and change the model? So forget about reimbursement and all these things. The cost of the test is not what it used to be 10 years ago. Now it's $100. Let's get everybody screened. Right? This is a change that we can do that will kind of like break all this pain that we are having with the relationships between labs and payers. And the same thing goes to whole genome sequencing. So yes, it produces a ton of data. Some of the data is extremely valuable, especially if you want to do prediction and analysis around that. Today at scale, you can do whole genome sequencing for less than $500. For less than $400. That is extremely valuable. Now, some companies that do this genetic testing, they are to figure out a way to reimburse many thousands of dollars. I think that's wrong. We need to find a way to break how it's been done. That's the whole relationship between the diagnostic companies, the labs, and the payers. There's a lot of other things payers need to worry about in the health system. If we're generating, I would argue more than 80% of the decision based on diagnostic data, right? We say 70%, I think today like probably 90%. So that will really, really change how data from diagnostics is the first step in care.
Yes, so that's a good point. So the economics are a little bit out of whack. It's sort of hard to even explain why, but the costs have come way down. The payer policy has not adjusted at the pace of that change. And that is a rate limiter for what you can really do in these research scenarios, right?
I think the research provides the other side of that coin, which is the business case that you need to take to a payer to be able to justify that cost up front. So if you run a research program which then shows that if this diagnostic happens, it changes physician and patient behavior, and that results in a better outcome and lower cost. Hinge Health did this very well, actually, when they were going to market for the first time. They ran studies which showed that their physical therapy app saved payers significant amounts of money for those patients who used it relative to the standard of care. And that was the vehicle, that was the business case then for large-scale payer adoption and, a fantastic success and impact on patients' lives. We need to be thinking about the same approach of saying, if we want to go to a payer and justify, even though the costs have come down, how can we run some research systematically with inside health systems and networks to be able to build those business cases? And again, and this is where the cost benefit comes in. It's not cheap to run studies traditionally. The innovative capacity of the research and healthcare system out there to be able to do that. But you're right, the challenge is that you have to often, to get the data to start with, you have to have some adoption. And that's where I think the the manufacturers and others can play a role here, is that they, it's in their interest to get large scale adoption of these labs.
Yeah, and maybe I'll add to what we just said, and what you're doing is extremely valuable to prove all this, studies and data. But I'm seeing also the home testing environment is changing dramatically. I'm seeing it firsthand. One of the companies I work very closely, we do kitting and fulfillment. Like, we manufacture the boxes that go to people's home and the whole workflow. That is growing exponentially now. A lot of companies, a lot of labs are looking how to send kits to people's home. And what it means is that people are willing to pay cash for these tests and not go through the whole, ask your doctor for a test. So these are the changes that patients are driving. Patients are willing to pay out of pocket $100, $200, $300. Sometimes it's better than, suddenly saying a report from the insurance company that the test was $5,000 and you have to pay $300 of that. Like, what? Just went through a whole circle, and I could have paid out of pocket and get the test 2 seconds, ordered and shipped to my home. These are the changes, and it's happening, and there's proof that it's happening through companies that are doing kitting and fulfillment and all that. We just also did a press release about how to close that when it comes to gaps in care.
Yeah, that's a very good point. The other aspect of this that you guys have me thinking about is the opportunity to use some of the advanced data science that we now have at our disposal, and AI included in this in a validated way, to make it possible for the caregivers to incorporate genomic information in a meaningful way to deliver care. And so you can get the kit easily, you can do the buccal swab, you can send it back and get all this data. And then if you think primary care as the centerpiece of your care journey, what if your primary care physician and their staff had a way that on an ongoing basis, the whole genome that they did is actually surfacing what the actionable screening approaches or things are that otherwise they wouldn't really know. And now you're bringing together the best of more conventional healthcare delivery with the best of what genomics have to offer. And we are actually seeing that firsthand with a company that has been rolling out capabilities to concierge, which obviously is for that tiny percentage of the population that is wealthy enough to buy concierge medicine. But I think eventually these kinds of capabilities will become standard of care. But it's this weird dynamic also where the lab is very limited in what they're allowed to share beyond just the report. A lot of people don't realize this, but because of the regulatory environment, can't send you a report that says, here are all the things you should do based on the information. The lab can basically send you the report, period. So then you have to have something in the middle that helps to translate that.
Interpretation of the results and the actionability is very important. And we're seeing companies emerging, focusing just on that. Like, how do you take all this information, in this case, maybe genomic information, and what does it mean, and what's the actionability? So that is a key component.
So I'd love to hear your thoughts on that.
It has to be based on grounded evidence. If you're making recommendations based on a genomic factor, it has to have some meaningful research behind it, because otherwise it's, we're in witch doctor land, and that's sort of my concern of some of the kind of consumer-based testing projects out there or companies out there, is that they are making recommendations which are not evidence-based. And I think that's very sad. So I think there's a risk of losing trust within inside those kind of the patient population as a result of that. I think one of the things that's exciting about sort of genetic side of this is there's so many things that are associated with your genotype that or your whole genome sequencing that we have no understanding yet of what that means in terms of, we have a very simplistic understanding currently of association of specific genotypes to increased risk of certain diseases or cancers and so on. If you can actually test a significant proportion of the patient population and then genuinely follow those patients over time, you build over the next 10, 15, 20 years, such rich data set that allows you to then retrospectively go back and say, what were the things in that genetic profile that were predictive of you getting X, Y, and Z? But you have to do that at a population scale because the only way it works to be able to get statistical significance. So when you go back to the 10 years time, you say, what's this association with this? You need to have a number of patients that's high enough to meet the statistical standard for research. So you can say that this wasn't chance, it actually was an association. So this is where you have to think about embedding research within inside the system as a whole.
So we're speaking somewhat in generalities now about conceptually what this is. But what really becomes powerful, and we talked about this some at our dinner and after dinner last night, are the stories that actually bring this home. So what is a story from this type of new connection into research with what I would call real world patient journeys, where it's not a contrived study. It's all these patients are going through their care, and why not package up that information that's being generated to become this live study? Is there a specific patient story or some kind of way to turn this into answering that so what question from a human perspective?
Yeah, I think it's really interesting. I think so much of this is about communication for patients, like helping them understand that when they're contributing to being part of a research, it's unlikely to benefit them directly. But what's so interesting is that through our experience of now doing this across UK and US at scale, patients just want to be able to feel that they're contributing to society and that their disease means something. If I've got diabetes, if I've got Parkinson's disease, there's not much I can do, but if I can fill out some surveys and give consent and allow us to be able to link health record data and completing genomics testing kits that I send at home, they get a huge amount of value out of that, especially when we provide that information back to them to say, we've just got a study published in Parkinson's disease, and we send an engagement back out to the patients that contributed to say, hey, here's a picture of Professor Wilson at this conference in Milan, presenting information that you contributed to that's going to change the way in which Parkinson's patients are going to be managed. The response to that is incredible. That's what people want. And I think being able to bring it back to those individual kind of stories, to your point of saying you're part of this research.
That's powerful. So we're saying that the community of people who are going through their care journey all of a sudden become part of the information that will ultimately result in some breakthrough. So if you have Parkinson's, for example, you could actually be contributing by just consenting into this program. Elliot, you could talk about it in terms of what type of program might align with this from a diagnostics perspective, to where if you're a caregiver that has patients that are consenting in this way, you are realizing that this research is so much more powerful if there's this layer of diagnostics that maybe historically would be the norm.
So, I think on the diagnostic side, I think there's so much opportunity to go to caregivers and health systems and say, look, you're collecting all of this data and paying for it as a cost center. But actually what we can do by engaging these patients at scale in a research program is turn that into start actually demonstrating outcomes in terms of reduction in healthcare costs because the patient has had this diagnostic, or we see a trend, we can use an algorithm to identify a risk profile of a patient. That's actually then resulting overall in 2 years' time in a reduction in cost of care for you as an ACO system. I think that's a really powerful narrative because, we have to be realistic that they are business-minded and driven. And although the patients often, we see fantastic engagement from patients based on altruism in the way that I've just described, we have to be able to describe this in the context of a business case for the health system. There's several elements to that I think this idea of effectively creating an engine to be able to turn diagnostics into a value driver for the health systems is a key part of it.
I'd love to hear your thoughts on this, Doug.
So education is key, and not necessarily always education to the patients, but also education to the provider. Many providers have an old PDF form that's their labs that they're requesting. It's crazy. I had that experience with a cardiologist that I said, hey, can you please add lipoprotein A? He's like, why? I said, because I want to know that data point. He's like, sure. So he adds it to the requisition form. Insurance covers it. I get my lipid protein that otherwise my cardiologist would not have in the list. So I think there's education that needs to be towards the caregivers and the providers that there is many types of biomarkers, genetic tests, we're talking some, microbiome testing, all the different types of tests that are available out there, to at least have that discussion that there are many more possibilities than there used to be. Some reimbursed, some cash, but this is kind of like the change. Now I believe patients are having discussions with their doctor and saying, hey, doctor, I want to do this test. I heard about it. Like, Function Health of the world, changing the game. They're making so much awareness about getting tested, and we didn't have that before. So how do we, in this room and all the people involved in diagnostics, leverage that to push diagnostics to the front as we believe that it should be, but the industry doesn't realize that. One of the things that we did, and HC1 and Boombostic became an immediate sponsor, was recognize that HLTH was the largest innovative healthcare conference in the industry in Vegas, big show, did not have any representation for diagnostics 2 years ago. So we approached the leadership and explained what diagnostics means, and all of a sudden now we have a diagnostic zone in the conference. A lot of companies in this room and friends are coming in and showing up to explain to the industry that, 80-90% of the decisions made in this whole hall room are generated from this little zone that we call the diagnostic zone. So there's a push, there's a movement, for people that come to Robert Michel's event, you see the power of diagnostics. Like, we talk to each other. How do we take that and bring it to the entire healthcare ecosystem? And then the caregivers will be aware that they can do the studies, and we're going to improve everything.
So to make things happen, you have to follow the money. And so I think this is a topic we haven't explicitly really talked about. And we hear a lot in diagnostics and in health systems. People now, they hear data and they think, oh, we have all this value. It's this gold that we should get something for. And I think in many respects, that view is a bit sophomoric and misguided, because any data set on its own without a significant amount of refinement to it and some type of action put around it, and oftentimes linking to other data, it takes something much bigger to actually create this value and unlock this value. Recently, labs, though, are thinking I should be getting some kind of remuneration if people are using my data. And then there's this whole question about whose data is it really? Is it the patient's data? I think we have some experts in our audience here from McDonald Hopkins who has a very clear view on how these things are treated. But I'm curious to know, in the UMed model or just in this research model, who's getting paid and by whom?
Yeah, it's a great question. I think that there's a lot to unpack there. But I think one of the things that's fantastic about research that's been it's an international model for how research is done. You have a protocol. So that allows a huge amount more capability in terms of linking data set, using it with third parties in many ways, in a way that are constrained when you're looking at the identified data set. So I think when you build a research model around the data, you create much more value to the data alone.
I think the data now with the power of AI is different than how we thought about it maybe 2-3 years ago. And there is a lot of power of connecting the dots and forming within our community partnerships that can help improve the value of the data. An example is what we recently, the press release that was done a few days ago.
Well, so there's this idea of gaps in care. And I think this is very much a related topic to who are you studying and who's diagnosed with what. And if people aren't getting diagnosed, you can't really know what it is that they have going on, or if you're not predictive about it, you're missing out on an opportunity to treat people in a way that gets them to the best outcome. So one of the things we focused on at HC1 is on this testing happening, like your example of the doctor has the PDF that has the standard set of tests that they run that they learned in 6 weeks of medical school 20 years ago. Things have changed quite a lot. And so what we're doing is using advanced data science and historical patterns, and a lot of really smart intelligence is built in to identify those people proactively who are, and then once you identify that person, you have to do some kind of diagnostic test in order to output the information to determine if there is actually a diagnosis there that requires some kind of an engagement around their care. So I think that certainly relates to this topic of how are you getting the testing done. But there's also the laws of physics in healthcare, which is there's only so much resource to go around within the healthcare system, and to actually go do that test requires an engagement with a patient. It requires a process for the kit. It requires the lab to do something. It requires information to then be generated, and then somebody to do something with that. It's like there are all these steps that on the surface it seems like, hey, no big deal. Why aren't we doing more of these tests? And there's this development around consumer testing that you raised, which is increasingly happening. I always refer to my functional medicine doctor, who is a pharmacist turned functional medicine expert, because she was fed up with the traditional way that prescribing was happening. I right now I have a kit sitting on a shelf at home, like collecting dust, where I'm supposed to go to the place, the PSC, to get a blood draw and send that in. And she wants me to do that on repeat. There's the microbiome aspect to that. It's not a very integrated, coordinated thing with my overall care. But what we're seeing in more of I would call the business to business world of more traditional healthcare delivery, and what we just announced with Simple Health Kit, is that now not only also then drive the process to do the collection in the home with the kit that's in a very consumer friendly approach. And it's still running through an order that's being generated like at the traditional provider level. But instead of just saying to the provider, okay, you guys go do something with this now, we're closing that loop. And what you're seeing also with this explosion of AI is this recognition that now you can't just report the news, you have to go make the news. Like the system has to do the work. Part of that is electrons, part of it's atoms. Like you actually have to move some kind of physical thing to go do a thing, to go close the gap. And so I think that type of a model where you're not just relying upon the healthcare system to figure out what to do and to do it, I think that's consistent with what you're talking about with these live studies. Is these are health systems that are already doing care, and they're not research centers that are already set up for this. And so you're expanding into this blue ocean that previously just wasn't touched at all.
If you do it well, which is, what we believe we're doing at UMed, is if you embed the process with inside routine care, then you remove the burden from the health system. So it's not something else that the physician or the nurse or the caregiver needs to do as part of the many different things that everybody needs to do. We just automate the process of outreach as part of their care process. We're sending you this testing kit. Would you also like to be part of a research program as well? If you do, here's information. And by doing that, you turn the whole process into a research program, which creates these downstream effects in terms of creating value both for the health system and for the patient.
What I learned from what you guys are doing at HC1 is not to be afraid to think out of the box about partnerships and actually go and do them. So I love that. We did that now pretty quickly with an opportunity that we had, what we described now. But I think there's a lot more partnerships that we can form among each other, not being afraid to think differently, to unlock something that, through discussion and through getting to know each other, that's when we discover how we can solve a problem.
Well, I think a systematic way of closing care gaps linked to what you're describing is something that ties it all together as an example. So because we are getting short on time, I wanted to make sure we opened up for the group. If there are any questions, if there's any feedback that you'd like to give on this topic.
As you are structuring this from a long-term research perspective, how are you handling either what I'll call unintended findings and or when new innovations come to marketplace around a specific assay that now has clinical relevance? How are you reaching back out and engaging the patients?
So it's a really important. We've actually got a project at the moment with the Michael J. Fox Foundation looking at a biomarker called alpha-synuclein in healthy patients to understand developing Parkinson's later in life. And this is where, again, UMed research has given us a framework to do this ethically and practically, in that when you engage patients in a research project and you're doing testing, you have the framework to be able to say, we're not going to give this information back to you in terms of what this diagnostic may mean, not because we don't want to, but because that creates huge risk in terms of before that research is done and it's integrated inside a healthcare system. We can't do that. So the whole point of research is we look at what happens. We look at a new biomarker, understand what that means in terms of the patient and society with those patients. It creates real risk if you start providing information back to say, hey, we think that you've got a 25% increased risk of Parkinson's because you tested positive for this in this research study. You create a whole can of worms there where, what does that mean for the patient? Creates huge anxiety. We don't yet know if that's true. We certainly don't know what to do about it. The point being is that research, as a framework that's been now well established for many, many years, gives us a way to be able to answer those questions.
The question is creating two separate diagnostic populations, and I'll explain quickly. So we're trying to push things from healthy, affluent patients to the entire population and creating another set of problems that we don't even know about.
I can comment briefly on that and then turn to you guys. I've actually seen and been party to some initiatives where there are revenue streams based on monetization of data within a healthcare system. It's a research system that in part is funding a pool of capital in a nonprofit focused on that, what I would call it the indigent population, the population that really isn't going to be able to afford or pay for it. Therefore, there's an ability to start generating, that data on that part of the population. So to have an economic engine to do that. Now, obviously, if the people aren't engaging with healthcare at all, there's no real way to get that information. But I do think there are some models that are emerging that can help fill that underserved gap.
Yeah, there's two parts to that question. One is data still we're collecting bias because it's not the same as every patient population. And again, this is where for us, it's really important to be able to integrate those when we're collecting data and generating research. It needs to be in populations that are very broad. And so the whole point of our technology platform is we can then integrate it into a community health system, even home care providers, in a way that even academic medical centers are not representative of most patient populations. If you go to Sloan Kettering's patient population for cancer, regrettably, that's not the patient population of most of the US or the world. So then there's a piece about how we do the process. And then I think the point about the back of that is that hopefully what that research then does is if there's a diagnostic test, then that should be then taken and integrated with inside Medicare or, into the programs that then are going to benefit those within society that don't have access to the testing that others.
There's clear separation between the ones that are in control of their health and doing a lot of things and those that don't even care, never go get tested, eat horribly, which is a whole other story about the food industry. I think that if I look at the evolution of technology and how everyone has today a smartphone, potentially everybody will be more aware of their health, and through these technologies will be given opportunities to maybe start getting a little bit more in control of their health. So I think there's hope through all the push that's being done on the consumer side. There's this effect of people talking to people. So if we all talk at our dinner tables with our friends about, I just did this test, it's so amazing. And then they talk to somebody and they talk to their parents and those parents talk to their friends. And all of a sudden there's an effect of more and more people realizing that these tests are really available. You just have to kind of look for them. If it's a very simple A1C that every person in the US must do, and through more complicated genetic stuff. But yeah, there is a separation that we have to figure out.
Thank you for the question, and thank you for being here, Dr. Matt Wilson, Elliot Josephson. I feel like this has hit another really important aspect of what's going on in healthcare today. And thank you for being part of the Healthcare Innovation Summit here in Indianapolis. I'm your host, Bradley Bostic. This is Boombostic Health in the Wild. Thanks for being here. We'll see you next time.